Okay, the nursing management. We always want to obtain a thorough history and physical exam. We want to watch for signs of any cardiac, pulmonary, cerebral, or lower extremity vascular problems. And we always want to establish baseline data in order to compare that post-operatively. Now we want to note the quality and character of any peripheral pulse and neurologic status, as well as mark or document the pedal pulse site and any skin lesion or lower extremity on the lower extremities before we go to surgery. And in the ICU, we always did that. When we found the pedal pulse, we would put an X with a marker on that site so that the next nurse, if it's not directly at that site, it gives you an idea of where you need to go to palpate that pedal pulse. We're going to monitor for any kind of indications of rupture, and those indications would be diaphoresis, pallor, weakness, tachycardia, and hypotension. We want to look for any abdominal, back, groin, or periumbilical pain, because those are also indications of rupture, as well as change in level of consciousness and a pulsating abdominal mass. Continuing in the nursing process, we are in the planning phase, and the overall goal is to restore normal tissue perfusion, that the person has intact motor and sensory function, and that there are no complications related to surgical repair, such as thrombosis, infection, and or rupture. As far as the nursing interventions or nursing implication phase of the nursing process, you actually can look at table 33-3 for reduction of risk factors. And examples of risk factors include controlling the blood pressure, smoking cessation, which in chapter 10 of our text, they talk about smoking cessation. If you want to go back and look at those things that they include for smoking cessation, increasing physical activity and maintaining normal body weight and serum levels are all a part of the health promotion. So we want to alert for opportunities to teach health promotion to these patients as well as their caregivers, and encourage these people to reduce those risk factors that we just talked about. And reducing those risk factors, that helps us to ensure the patency of the graft post-operatively. In acute care management of these patients, you want to again do patient caregiving teaching and provide emotional support for the patient and caregiver. And we want to carefully assess all of the body systems. Pre-operatively, we want to, although pre-op routines may vary from institution to institution and from surgeon to surgeon, there are some general things that we will do pre-operatively, and that is one, doing routine bowel preps before surgery. We want to keep the patient NPO, make sure that they have had a shower prior to the procedure, and we want to give IV antibiotics right before that incision is made, so that actually will be done in surgery, that initial IV antibiotic. We also want to pre-operatively tell the patient what to expect post-operatively, and the expectations that they're going to encounter in the recovery room, that they'll be having tubes and drains, then they'll move from recovery to the ICU, and that they may be on beta blocker drug management. The patients with a history of cardiovascular disease are the ones that usually receive a beta blocker pre-operatively, and that beta blocker is usually metoprolol. Post-operatively, Patients that have had aortic surgery, they typically go to an ICU for 24 to 48 hours for close monitoring. Once they get to the ICU, they may have an arterial line in place. They have a CVP or a PA catheter in place, may be mechanically ventilated, have peripheral IV lines, as well as have an indwelling catheter at that point, because as we talked about earlier, if it involves tumors above the renal arteries, we have to make sure that they have adequate renal perfusion, which is evidenced by urine output. So the best management for that initially is having that urinary indwelling catheter placed. We want to monitor NG tube function and output. They are definitely going to be on a continuous ECG monitor, have a pulse ox, and we have to do pain management with these people as well. A nursing care plan for the patient with aneurysm repair or any other aortic surgery. They do have a e-care plans connected to your Lewis text that you can look up and see what nursing diagnoses would be appropriate for this patient. So post-operatively, we want to maintain graft patency. So an adequate blood pressure is important to maintain graft patency. So prolonged low blood pressure may result in graft thrombosis. We want to give drug therapy for severe hypertension, which consists of giving IV diuretics such as Lasix, IV antihypertensive medications such as nitroprusside, which is Preside. They may give Esmolol, known as Brevibloc, or they may give labetalol, and that is also known as Trandate or Normodyne, are the drugs that may be indicated for these patients. As far as the cardiovascular status, again, we do the continuous ECG monitoring, because myocardial ischemia or infarct may occur in the perioperative period due to decreased myocardial oxygen supply or increased myocardial oxygen demand. Cardiac dysrhythmias may occur due to electrolyte imbalances, hypoxemia, hypothermia, or myocardial infarction. So these are a list of the things that we will do for these patients post-operatively. And as it says here, continuous ECG monitoring, electrolyte monitoring, arterial blood gas monitoring, oxygen administration, anti-dysrhythmic and antihypertensive meds, pain control, and any cardiac meds that these patients were on need to be resumed. Now, all IV, arterial, CVP, or PA catheter insertion sites should be cared for by using strict aseptic technique, because they are ports of entry for bacteria. Meticulous perennial care for the patient with an indwelling urinary catheter is essential to minimize the risk of the development of a urinary tract infection, and we always want to keep the surgical incisions clean and dry. So post-operatively, for signs of infection, we would look at temperature on the patient. We'll monitor the WBC when we do the lab study. We draw CBC, but the focus will be the WBCs. We also need to ensure adequate nutrition, because nutrition plays a vital role in recovery, and observe those surgical sites again for signs of infection. Excuse me. GI-wise, post-operatively during the acute care phase, when or after open abdominal aortic aneurysm, a paralytic ileus may develop as a result of anesthesia and handling of the bowel during surgery. The intestines may become swollen and bruised, and peristalsis cease for variable intervals. So a retroperitoneal surgical approach can be used to decrease the risk of bowel complications And clinical manifestations of bowel ischemia includes absent bowel sounds, fever, abdominal distension, diarrhea, and bloody stool. So again, we will be assessing that patient for bowel ischemia, and as it says here, indication of returning of normal bowel function is the passing of gas or flatus. So make sure that we do a good abdominal assessment and that we are recording the character and amount of the actual NG tube output. Neurologically, when the descending aorta is involved, neurovascular assessment of the lower extremities is important. So we want to check the skin temperature and color, capillary refill time, and sensation and movement of the extremities. So during that neurologic status assessment, you look at level of consciousness. Again, it'll be a good time to utilize the GCS, your Glasgow Coma Scale, that looking at pupil size and reaction to light, facial symmetry, the speech, ability again to move upper extremities, and the quality of the hand grasp. And you can collect that data by just using your Glasgow Coma Scale for that assessment. Post-operatively, I don't know why this screen seems like it's pulsating. I hope it don't come out too bad on the actual recording, but it looks like it's just flickering in and out for some reason. But anyway, as far as peripheral perfusion status, we always want to assess the pulses, and again mark the location of those pulses with a felt tip pen, or we use those little black markers. You should check and record all the peripheral pulses hourly for several hours and then routinely, and all this is based on your institutional policy. And when the ascending aorta and the aortic arch are involved, we want to assess the carotid, radial, and temporal artery pulses. For surgery of the descending aorta, we want to assess the femoral, popliteal, posterior, tibial, and dorsalis pedal pulses. And again, we want to mark those pulses once we locate them. We look at the extremity assessment because occasionally lower extremity pulses may be absent for a short time after surgery as a result of vasospasm and hypothermia. A decreased or absent pulse together with a cool, pale, mottled, or painful extremity may indicate immobilization or graft occlusion. Well, embolization, not immobilization, I'm sorry, embolization or graft occlusion. And we want to report these findings to the physician ASAP. And with these people, you may have to use a Doppler to assess those pulses. It's not hard. You get some lubricant gel and put that on the site and turn on the Doppler and listen for pulses, or you sometimes can hear the actual blood flowing through that particular vein where you're trying to palpate that pulse. As far as renal perfusion, in the immediate post-op period, we want to record those hourly urine outputs. Again, that's why that indwelling catheter is important. And a lot of times when you're doing hourly urine output, you will see a urometer has been attached to the Foley bag for accurate hourly urine output. You want to maintain adequate fluid intake and output and record daily weights until the patient resumes a regular diet. Decreased renal perfusion can occur from embolization of the aortic thrombus and or plaque to one or both of the renal arteries. This will cause ischemia of one or both kidneys, and when that happens, you will see the presence of hypotension, dehydration, prolonged aortic clamping during surgery, or blood loss. All of these can lead to that decreased renal perfusion. And an indication, again, is the monitoring of that urinary output. It will tell you about adequate renal perfusion. We also want to utilize our CVP and PA pressures. When the CVP is low, that is an indication that the patient is lacking volume. So we want to increase the volume with these people with the IV fluids that they're receiving. And then we want to monitor the BUN and creatinine, because again, that is an indication of renal functioning. Now, as far as ambulatory care, we want to encourage the patient to express concerns. We want to instruct the patient to gradually increase activity. No heavy lifting. We want to teach the patient and caregiver about signs and symptoms of complication, and those are usually infection and neurovascular changes. Fatigue, poor appetite, and irregular bowel habits are common. And any redness, swelling, increased pain, drainage from the incision, or fever greater than 100, that needs to be reported, because those again are signs of infection. Sexual dysfunction is also common in males after aortic surgery, so this could be a part of the patient concerns. Preoperatively, we want to document the baseline sexual function and recommend counseling as appropriate, and a referral to a urologist may also be useful if erectile dysfunction does occur in these people, especially the males. Expected outcome, we're in the evaluation phase of the nursing process. Our expected outcome would be patent arterial graft with adequate distal perfusion, adequate urine output, and no signs of infection. So in order for this to be your expected outcome, you should have had these included in your plan, as well as interventions that are directed back to making sure that all this happens. So in the end, you want to evaluate either this happened or it didn't. They had no signs of infection, or they developed the infection. They had an adequate urine output, or they didn't have an adequate urine output. And if they didn't, then you have to show where you intervened again in order to be assured that that is restored. And again, we want to make sure that they have a patent arterial graft and that they are having adequate distal perfusion. Now, the next slide is going to talk a little bit about aortic dissection. That dissecting aorta. So a lot of times, aortic dissection, again, I just said dissecting aneurysm is usually what it is referred to. And an aortic dissection results from the creation of a false lumen between the intima, which is the inner lining, and the media, which is the middle layer of the arterial wall. Aortic dissection is classified based on the location of the dissection and the duration of onset. A type A dissection reflects the ascending aorta and arch. A type B dissection begins in the descending aorta. Dissections are also classified as acute, and that usually occurs in the first 14 days. Subacute is 14 to 90 days out, or chronic is greater than 90 days based on the symptoms onset. Now these next let me see, 2 slides. Well, we got a couple pictures here, so let me show you these pictures. And I just said that I got a little ahead of myself telling you about the classifications. Again, type A dissection affects the ascending aorta and arch, and type B dissection begins in the descending aorta. And this is what a torn intima look like, because again, we were just saying that this occurs with the intima, which is the interlayer, and between the middle layer is where this tear usually starts. So this is giving you an example or a picture of what that looks like. And then this is a photo of a aortic dissection of the thoracic aorta, and it shows you where the heart is at the top on the left, then where the actual dissection happened, and you can see that it's just above the renal, the kidneys. So you can see how easily the kidneys get affected and how close these structures are in the body, and why it's vitally important to monitor renal function. But that is the picture of a dissected thoracic aortic aneurysm. Yeah, aorta of the thoracic area. So the etiology and pathophysiology is due to degeneration of the elastic fibers in the arterial wall. Chronic hypertension actually speeds up that process, and a tear in that inner layer allows blood to track between that inner and middle layer. Again, that's kind of explaining this particular slide right here, what actually happens in that slide. So as the heart contracts, each systolic pulsation increases pressure on the damaged area, further increasing the dissection, and it may end up occluding major branches of the aorta, and that in turn will cut off blood supply to the brain, abdominal organs, kidneys, spinal cord, and extremity. So as you can see, aortic dissection is very critical. I have known people to have elective AAA surgery, and it has not been successful, especially in the elderly. And I honestly have not seen a lot of successful recoveries from AAA repair. So in the clinical manifestations, it depends on the location of intimal tear and the extent of the dissection. In the acute type A aortic dissection, it has an abrupt onset of excruciating anterior chest pain. And in the acute type B aortic dissection, it's most likely to report pain located in the back, abdomen, or leg. The pain is frequently described as sharp and the worst pain ever, or as a tearing, ripping, or stabbing type pain is some of the terminology that's used to describe the pain. That pain is characterized by sudden severe pain in the anterior part of the chest, or intrascapular pain radiating down the spine to the abdomen or legs. It can be described again as sharp and the worst pain ever, and it may mimic the pain of an actual MI. But dissection pain can be differentiated from MI pain, that it is more gradual in onset and has increasing intensity. As the dissection progresses, pain may migrate and follow the path of the dissection. And older patients are less likely to present with abrupt onset of chest or back pain, and are more likely to present with hypotension and vague symptoms. Cardiovascular, neurologic, and respiratory signs may be present in these people. Neurologic deficits may include that altered level of consciousness, weakened or absent carotid and temporal pulses, and complaints of dizziness or syncope. The patient may develop angina, MI, and a new high-pitched heart murmur. In severe cases, these complications can result in left heart failure, where the patient will present with dyspnea, orthopnea, and pulmonary edema. It can progress to cardiogenic shock and lead to death. So as it states here, in If the aortic arch is involved, you're going to see neurologic deficiencies. And in a type A aneurysm, disruption of blood flow in the coronary arteries and aortic valve occurs, and you end up with aortic valve insufficiency. And it talks about the development of that cardiac tamponade, which you already have had a clinical case with cardiac tamponade, and that tamponade is a severe life-threatening complication, and it occurs when blood escapes from the dissection into the pericardial sac. Again, those clinical manifestations, if your patient is having a cardiac tamponade, and in chapter 36 there is a lot of detail, or it goes in detail about a cardiac tamponade. But with those patients, you're going to see the clinical manifestations of hypotension, a narrowed pulse pressure, distended neck veins, muffled heart sounds, and they will develop pulsus paradoxus. That aorta may rupture, resulting in exsanguination and death. A hemorrhage may occur in the mediastinal, pleural, or abdominal cavities. An occlusion of the arterial supply to vital organs may occur as well. So you will see symptoms of spinal cord ischemia. And again, they are ranging from weakness and decreased sensation. They are rarely do they have complete lower extremity paralysis. That is rare, but not impossible. Renal ischemia leads to renal failure. And anytime you have manifestation of abdominal ischemia, meaning the mesenteric of the abdominal area has no blood flow, that can occur and cause that abdominal pain, as well as decreased bowel sounds, altered bowel function, and ultimately bowel necrosis is what happens when you have disruption of that blood flow to the vital organs. And right now, in particularly, we're talking about the renal and still parts of the GI system. So, diagnostically, a chest x-ray can show a widening of the mediastinum and pleural effusion. You might do a 2D, 3-mode echo, or a 3D CT scan, and they can do the TEE, the transesophageal echo. They actually have become the 3D CT scanning and the TEE, the transesophageal echo. They have actually become the standard of care for the diagnosis of acute aortic dissection. A CT scan or MRI can provide more detailed information on the severity of the dissection and related complications, such as pericardial effusions and carotid dissection. And the TEE is preferred in a very unstable patient, or those with contraindications to CT or MRI. And that's usually those patients who have some type of metal implant, or they are actually allergic to the contrast media. Our initial goal is heart rate and blood pressure control, because a low blood pressure and myocardial contractility to diminish pulsatile forces within the aorta. That is why we really want to pay much attention to these particular areas. And again, if the blood pressure is low, that means tissue perfusion and organ perfusion is low. And if you're not having a strong myocardial contractility, it's going to result in diminished pulses within that aorta. So that is so important to monitor that heart rate and blood pressure, and again, to manage the pain. So with these people, we will do drug therapy with IV beta adrenergic blockers like the Esmolol. We want to titrate that to a target heart rate of at least 60 beats per minute or less, or to a systolic blood pressure between 100 and 110, because you don't want these pressures to be too high, because you don't want to blow the graft site on these patients. The same with the carotid artery dissection or carotid endarterectomy. When they've had plaque in the carotid arteries, it is important that we maintain that blood pressure at a certain level, because you don't want to blow that graft. As far as treating that pain, as we said on the previous slide, pain management was important. They usually going to use morphine, because that is the preferred analgesic, and it actually decreases sympathetic nervous system stimulation in addition to relieving the pain. And then other antihypertensive drugs they use to treat that blood pressure is calcium channel blockers, and our biggest one is Cardizem that we use. And we mentioned nitroprusside, and that's nipride, but you have to really watch your patient, because patients are very sensitive to nipride. You give them 2-3 drops and look at, and your next 15-minute blood pressure be very low. And then we talked about the angiotensin converting enzyme inhibitors, as well as other antihypertensive drug therapy. As far as conservative therapy, the patient with the acute or chronic type B aortic dissection without complications can be treated conservatively. So in that conservative therapy, if no symptoms, again, can be treated for a period of time using these conservative methods. But we want to make sure that they have pain relief, that their heart rate and blood pressure is under control, that they are trying to modify any cardiovascular disease risk factors, and they may require close surveillance with a CT or MRI. We have that thoracic endovascular aortic repair, which is the T-bar. It's standard to treat acute and chronic type B aortic dissections with complications. The T-bar is similar to the E-bar. A temporary lumbar drain may be inserted for cerebral spinal fluid removal to reduce spinal cord edema and prevent paralysis. And if a lumbar drain is used, strict aseptic techniques are essential to avoid introducing any type of infection. And with surgical repair, the mortality rate is about 50% within 48 hours of symptom onset. So emergency surgery for acute type A aortic dissection is pertinent when drug therapy is ineffective or when complications of aortic dissection are present, and surgery is delayed to allow edema to decrease and permit clotting of blood. If any of these happen, again, that mortality rate decreases by 50% within 2 days, 48 hours of the patient actually having an onset of symptoms. So you really got to be up on your assessment signs to be able to decipher what's going on in that patient. And remember, we're talking about emergency situations. So emergency surgery will be required for acute type A aortic dissection, but you got to know the signs and symptoms. They may require surgical repair when drug therapy is ineffective or when complications of aortic dissection are present. And again, it says surgery may be delayed in order to allow edema to decrease and permit clotting of blood, because you don't want the patient to be in symptoms of DIC prior to surgical therapy, because that increases the risk of that patient bleeding out severely during the procedure. That surgical therapy involves restriction of aortic segment and replacement with the synthetic graft material. And we kind of talked about those materials previously. In-hospital mortality and neurologic complications in these patients are very high. Open surgical repair is recommended for patients with a chronic dissection that have a connective tissue disorder, and it is recommended for a descending thoracic aorta with the diameter greater than 5.5 centimeters. Causes of death include aortic rupture, mesenteric ischemia, MI, sepsis, stroke, and multi-organ failure. So some of these things we've already kind of talked about, but we are just about done with this part of the presentation, and I think we'll move on next to strokes. If I can get through strokes pretty quickly, I may go back and take down the hyperlink that I did for spinal cord injury. I don't know, again, if I have it in me to go back through 4 hours of lecture on that, but I was really trying to do something new. And again, I had my had it where you can actually see me doing a presentation to make it feel more like an in-class type thing. So I am going to, I paid for that service yesterday, because a lot of these services they mentioned, they are not free, and if they are free, it is a great limitation as to what you can upload. So finishing the aortic dissection in nursing management, dissection, I'm sorry, in nursing management. In the preoperative, these particular measures actually help to keep the heart rate and systolic blood pressure at the lowest possible level that maintains vital organ perfusion, and that's typically a heart rate less than 60 with a systolic blood pressure between 110 and 120. And to prevent the extension of the dissection, we want to manage the pain and anxiety, because they can cause elevations in the heart rate and systolic blood pressure. So again, we want to keep them in a semi-phallus position, maintain a quiet environment. We want to relieve any anxiety and pain by using opioids and tranquilizers as ordered. You may use a benzodiazepine such as Ativan for the anxiety, and again, morphine for the pain management, and continue IV administration of any antihypertensive drugs. And we mentioned several of those drugs that we could give IV. Nipride is a drug that we give to lower the blood pressure. We can give IV metoprolol as well as labetalol, and it even talked about calcium channel blocker, and we can give that IV, and that would be cortisone. Continuing with the preoperative therapy or treatment, we want to get that continuous ECG and intra-arterial pressure monitoring, so they'll have an art line observation of changes in quality of peripheral pulses, and we will do frequent vital signs. We sometimes they can be as often as every 2 to 3 minutes until we reach that target blood pressure, and especially if they on nipride and you titrate, and you can set the automatic blood pressure to go off every minute, every 2 minutes, every 3 minutes. You can set it until you see that blood pressure and get it to where you want it to be, and then you observe at what rate or drips that you have the medication infusing, and know that that's your good baseline for maintaining your patient at the desired heart rate and blood pressure. If the arteries branching off the aortic arch are involved, we want to monitor the patient's level of consciousness, cranial nerve function, limb movement, sensation, and strength is what we want to monitor if the branches of artery off the aortic arch are involved. Post-operatively, we talked about seeing the aneurysm as far as the post-op care. It's the same as what we talked about in the aortic aneurysm. Most of all, the patients need to understand that antihypertensive drugs must be taken daily for the rest of their lives. And again, those beta-adrenergic blockers like metoprolol, and a lot of times they use metoprolol XL, which is the extended release. They use that to control the blood pressure, and those drugs actually decrease myocardial contractility as well. And the most common cause of death in long-term survivors is rupture of the aortic from redissection, or development or formation of an aneurysm has occurred. So in the discharge teaching, again, you want to maintain the therapeutic regime of the antihypertensive drugs and help them to know what some of the side effects are of those drugs depending on which one they are taking. And if pain returns or symptoms progress, you want to instruct the patient to seek immediate help. So pretty much that is it, and ends the presentation on dissecting aorta. And let me see, we will not go into peripheral artery disease. Those are the only two that were actually listed on our reading assignment. And I have a question. Following an aortic aneurysm repair, the patient suddenly develops severe pain in the right lower extremity. The right pedal pulse is decreased and the right foot is cool and pale. Which complication should the nurse suspect? A, hypothermia. B, wound infection. C, bleeding from the graft site. Or D, embolization or graft occlusion. So let me know the answer to that question on the discussion thread. I appreciate it very much. That ends this presentation.